Everyone. Thank you for being here for today's class. Our class this evening is Diagnosis Dementia, Now What? And my name is Lindsay from Insight Memory Care Center. I'll just briefly recap something we talked about in our last webinar. What's normal with age? There are changes that occur in our brains as we age, and they're to be expected. You might find yourself walking into a room and thinking, what did I come in here for? But a few seconds or even a few minutes later, you remember and you complete the task. You might lose something from time to time, but you can walk backwards in your mind and find that missing item. You might forget about an appointment, but you remember it later, right? These sorts of things happen once in a while. They might be irritating, but they're not actually getting in the way of everyday life. And then there are warning signs of something that's a little bit different than normal aging. This is a list from the Alzheimer's Association, 10 warning signs. So some of the warning signs that you see here on the screen include memory loss that disrupts daily life. So especially short-term memory loss, forgetting about things that recently happened, forgetting really important information that you just learned. Also, other warning signs include difficulty with familiar tasks like driving and bill paying, confusion about time, place, difficulty in communication, with word finding or following a set of instructions, losing things, poor judgment, withdrawal from work, social activities, changes in mood. There are a number of different warning signs that someone might experience that are a bit different than what we would consider normal aging. Before we get to the term dementia, I want to address the term mild cognitive impairment, or MCI. Mild cognitive impairment means there is a cognitive change that's more severe than what's considered normal for age, but it's not severe enough to get in the way of everyday life. So you might have more memory problems than what would be considered normal aging, but it's not significantly getting in the way of your ability to participate in daily activities. So mild cognitive impairment is technically not considered a form of dementia, but having a diagnosis of MCI does increase risk for later on being diagnosed with Alzheimer's or another type of dementia. So now what you see on the screen is a graph that shows the green lines at the top, normal aging. A little bit of change, but nothing significant. And then we see in the middle, MCI. We know there are some changes happening, people are starting to notice them, but that person still can complete their activities of daily living. They're still able to get through the day pretty independently, without much difficulty. We see as those changes continue, we would call that dementia, and I'm going to come back to that in a moment. But I want you to look to the left side of the screen. Before MCI, we see something that says preclinical. So this is a phase of changes happening in the brain, but they're not identified on cognitive testing, right? Other people probably don't even notice changes happening. For the person experiencing the changes, they may notice a bit of change, but it's nothing very significant. So there are changes happening in the brain with Alzheimer's disease for 10 to 20 years before symptoms ever start to emerge. So we see that when someone has MCI or has dementia, it's not like it just happens overnight. There's all these changes going on even before those symptoms start to emerge. So what is dementia? Dementia is not one specific disease. Dementia is a general word that we use to describe a set of symptoms. Symptoms that might affect memory, language, social abilities, different kinds of cognitive abilities. And these changes are severe enough that they are getting in the way of everyday life. So they are more severe than normal aging, and now they are getting in the way of everyday life. That's the difference between MCI and dementia. MCI, not getting in the way of everyday life yet. Dementia, yes, starting to cause problems every day. So as I mentioned, not a specific disease. Sometimes dementia is called neurocognitive disorder if you're more on the professional side of things. When someone is experiencing dementia, it means that there is changes in at least 2 areas of cognition. And so some that you see here on the screen, that ability to acquire and recall new information, you probably recognize that from Alzheimer's disease. Reasoning and handling of judgment changes. Sorry, my screen has decided to flicker. There we go. You might notice poor judgment. You might notice changes in visual spatial ability. So if you remember from our last webinar, these are not problems with the eyes. This is a problem with the brain understanding what the eyes see. So having difficulty with visual spatial ability might mean things like difficulty with depth perception, with color contrast. There may be changes in language function, changes in personality, behavior. You know, there are significant changes that are starting to occur. So generally, when we think about dementia, it includes a memory impairment. When I start talking about different forms of dementia, you will see that in the early stage, memory is not necessarily affected for a number of different forms of dementia. But quite often when we talk about dementia, there's sort of an assumption that there's a memory impairment included. So that might include aphasia, which is the inability to use and understand language effectively, and difficulty understanding what's being said to me or being able to communicate my message back out to you. Apraxia, the inability to coordinate purposeful movement, so things like being able to utilize utensils while you're eating. Agnosia, the inability to recognize familiar things or people, you know, not recognizing the people near you, or how to use different kinds of objects. And there might be impaired executive function, you know, that ability to organize and kind of regulate emotions and impulses. This starts to change too. So I mentioned that dementia is an umbrella term. So here's my umbrella for you. We're going to get to some of the types of dementia on the left side of the umbrella, but first I want to address some of the conditions on the right side under reversible. There are a number of different conditions, illnesses, diseases, temporary conditions that can cause these dementia symptoms, that can cause changes in cognitive function that are getting in the way of everyday life. But this underlying cause could be treatable or reversible. So for example, if someone had an infection, like a urinary tract infection for an older adult, that can really mess with their cognitive abilities until they get the right treatment, right? You identify the cause of these symptoms, the infection, you get on the right type of treatment, like a medication, an antibiotic, and within a few days or a week later, you're back to normal. Depression could be one of those things that gets mistaken for dementia. Unfortunately, just due to someone's age or family history, there's often an assumption that dementia is at play when it might just be depression that hasn't been identified or hasn't been treated properly. It could be like a brain tumor, it could be a metabolic disorder, like a thyroid condition, a medication side effect, or an interaction between two medications that's causing some cognitive change. But when the medication is changed, cognition clears, goes back to normal. Could be a vitamin deficiency, like a B12 deficiency. Could be alcohol use that someone isn't aware of, and maybe a friend, a family member is misusing alcohol. But if I didn't know that, I would think maybe that you had an irreversible form of dementia. You don't remember the things I told you yesterday. You've been falling a lot, you know, those kinds of things. There are lots and lots of reasons that someone might experience these dementia symptoms, but it could be treated or reversed. So let's say this person goes to their doctor. The doctor really is trying to work their way through all of these possibilities to identify the cause of the symptoms. So they may be identified, okay, it's not an infection, it's not depression, it's not a brain tumor, it's not any of these things. Now we need to start considering some of the irreversible types of dementia. So we're going to talk about the types that you see there on the screen: Alzheimer's, vascular dementia, Lewy body dementia, and FTD. The most common cause of dementia is Alzheimer's. About 60 to 80% of people who have dementia have this disease happening in their brain, this specific pathology. We know that Alzheimer's disease is irreversible. It has a slow, steady path of progression. So if you think back to the chart that I showed a couple of slides ago, that's really illustrating Alzheimer's disease, just kind of a gradual change over a period of time. We know it's a degenerative disease, which means that brain cells are dying. It leads to memory impairment. That's usually the first warning sign that a lot of people recognize in a friend or a family member. but it doesn't only affect memory. Alzheimer's disease affects a person's ability to complete their ADLs, which means activities of daily living. This is things like getting dressed, handling your business in the bathroom, eating on your own, those kinds of things. Having Alzheimer's disease means that there will be some behavioral changes in the future. We're going to talk more about those next week, so if you're interested in that, please join us then. And ultimately, Alzheimer's disease results in death. Eventually, brain cells have died in so many different parts of the brain that the brain just really can't function anymore. It can't send the right signals to the body to sustain life. When we think about Alzheimer's disease, we generally think about people who are older adults over the age of 65. There are a small number of people who are younger than 65 who are diagnosed with Alzheimer's, and we usually call that younger onset, or you'll hear some people call that early onset. Risk factors for Alzheimer's, we know that age is the primary risk factor, but also family history and genetics can play a role, usually just with increasing risk. Usually it's not a genetic mutation. That is possible, but that's like less than 1% of all people with Alzheimer's have that genetic mutation component in their risk. We know that brain injuries increase risk for Alzheimer's too, and there are a number of other suspected risk factors. The hallmark pathology of Alzheimer's disease are these plaques and tangles. Really, upon autopsy, this is what a coroner would be looking for to definitively say that someone did in fact have Alzheimer's disease. They're looking for the number of plaques and tangles in the brain. So the plaques are these deposits of a protein fragment called beta amyloid, and they build up into spaces between nerve cells. Then the other type of, the other hallmark are these tangles, these twisted fibers of another protein called tau that build up inside the cells. So you see there on the screen in that graphic of the brain, on the left is a normal brain, normal healthy adult brain, and on the right we see these plaques and tangles. The plaques are those kind of brown lumps that are looking like they're floating out there in space, and then those tangles are those smaller spots that are right there inside that yellow neuron or nerve cell. The second most common type of dementia is vascular dementia. Vascular dementia really occurs because there's reduced blood flow in part of the brain. For example, there was a stroke or a series of mini strokes, and the blood flow did not get through where it needed to be. The nerve cells suffered and eventually died. Now, the thing about vascular dementia is it's really different from person to person because it depends where those strokes occurred in the brain, how many there have been, how significant they were, and all of that information shows, we learn that through the symptoms that someone is experiencing. If I've had a number of mini strokes and I'm having difficulty getting my words out, we know that a lot of those strokes occurred in the language part of the brain. But maybe I have vascular dementia, I've had a number of mini strokes, and my balance is really impaired. I'm falling a lot. And there are other cognitive changes happening too. We know that those strokes were happening in a different part of the brain. So generally, having vascular dementia is linked to underlying cardiovascular or cerebrovascular diseases. Now you see in the corner of the screen, there's a picture of stairs. One of the main differences, at least kind of symptomatically, what you would see as a family member or a friend, Alzheimer's disease, like that graph, is just kind of a gradual change over a longer period of time. There might be bumps in the road, but there's not generally a significant, kind of dip in what's going on. With vascular dementia, it has more of a stepwise progression. So you're kind of right here, and then you have a vascular incident, like a stroke, and now you're here. And then you stay right there until there's another vascular incident, and then you drop down a notch, right? And that's the way that this type of disease progresses. The next most common form of dementia is called Lewy body dementia. And Lewy bodies are abnormal clumps of a protein called alpha-synuclein that accumulate in neurons. When we say Lewy body dementia, it really can mean two different things. Lewy body dementia is like its own mini umbrella under this larger dementia umbrella. So Lewy body dementia can mean dementia with Lewy bodies, DLB, or Parkinson's disease dementia, PDD. So both of these diseases share many clinical and pathological similarities, and sometimes they're referred to as different points on a spectrum. So I'll start with dementia with Lewy bodies. Dementia with Lewy bodies, some of the first signs that you might notice are changes in attention and executive functioning. Other pretty common symptoms include fluctuating cognition, where it might seem like my loved one is just kind of like their normal self for a while, maybe for a few hours, maybe for a couple days, and then there's a significant change, and maybe my loved one is, much more confused or paranoid, or, just like, whoa, what happened here? And then a little while later, doing much, much better. Feels kind of like a roller coaster with this cognitive ability. Another common symptom is hallucinations. So hallucinations, generally we think about visual hallucinations, where someone, believes that they're seeing something that's not actually there. If I thought that I had cats running around in the room right now, and there are none, that would be a hallucination. Hallucinations don't have to be just visual. They could be auditory, they could be tactile. Not everyone with dementia with Lewy bodies has hallucinations, but they're pretty common. With dementia with Lewy bodies, you also notice these spontaneous features of Parkinsonism. So it's not Parkinson's disease, but some similar symptoms. So that might mean, difficulty with gait, losing balance, shuffling feet, maybe a tremor, maybe some of the autonomic changes that occur with Parkinsonisms. There are cognitive changes, and there are some physical changes, physical symptoms that may occur too. But with dementia with Lewy bodies, the cognitive changes happen first, and the physical symptoms either start happening around the same time or later. Now, Parkinson's disease dementia. Probably many of you are somewhat familiar with Parkinson's disease. It's also a neurological disorder. It's more of a movement disorder. So with Parkinson's disease, there are lots of physical changes happening, but about 50 to 80% of people who live with Parkinson's will eventually develop the dementia side of things, the Parkinson's disease dementia. So when someone has Parkinson's disease dementia, they've had Parkinson's for at least a year or more. Often it's many, many years. And then later on, they're developing some of these cognitive changes. So a lot of these cognitive symptoms can be really similar to what I just talked about with dementia with Lewy bodies. Fluctuating cognition, hallucinations, some of these changes are pretty common across both diseases. There's another family of dementias called frontotemporal degeneration, or FTD. So this is a group of brain disorders that include BVFTD, stands for behavior variant FTD, and that means there are a lot of behavioral changes that are the first symptoms of this disease. PPA is primary progressive aphasia. With aphasia, we're thinking about language changes, those being some of the primary symptoms early on. When someone has frontotemporal degeneration, these are diseases that are primarily affecting the frontal or temporal lobes of the brain first. So things like memory loss, that's not one of the first symptoms in FTD. The first symptoms would be these changes in behavior, like losing your filter, not realizing when maybe you shouldn't say something, having some apathy, some withdrawal, having changes in language, significant changes in like word finding ability or understanding what someone else says. So generally, when someone has FTD, the onset is a bit younger than with Alzheimer's disease. So if you recall, with Alzheimer's, most of the time we're talking about people over the age of 65. With FTD, generally the onset is in the 50s and 60s. So the dynamics are a bit different. These might be folks who are still, very actively in the workforce, who are raising children, have kids in high school, have kids in college. So it's just a kind of a different layer of challenge for families who are facing FTD. And there are lots of other types of dementia as well, which we won't go into, but they include Huntington's disease, Creutzfeldt-Jakob disease, Wernicke-Korsakoff syndrome, normal pressure hydrocephalus, HIV-associated dementia, and CTE. There are lots of others as well, but these may be some of the ones that you hear about more often. And then there's something called mixed dementia, which just means that someone has more than one type of dementia happening at the same time. Most often, this is in people over the age of 80, and the combination is Alzheimer's disease and vascular dementia. But it could be younger than 80 as well. It could be other combinations of diseases. It could be 3 types of dementia. It just means that there's more pathology happening simultaneously. So maybe you're wondering, how is dementia diagnosed? There are all these different types of dementia. There are things that are treatable. There are things that aren't. How am I supposed to know what's going on with my loved one if we don't yet have a diagnosis? Or, well, maybe my loved one's physician made a diagnosis, but I don't really know how they came to that conclusion. So the first stop in getting a diagnosis is with a primary care physician. The person who really has that full medical record, who knows kind of lifestyle, who knows medications, who knows family history, who's going to check kind of all the usual suspects when there's a physical or cognitive change for someone. So that primary care doctor is going to do that complete medical history if they don't already have it. They're going to do a physical examination, neurological examination, checking for things like reflexes. The physical examination I should have mentioned, checking things like blood pressure, pulse, weight, those kinds of things. There could be some brain imaging involved, especially ruling out something like a stroke or a brain tumor. If someone is then referred on to a specialist, like a neurologist, there may be additional brain imaging like PET scans, MRIs, CT scans, or being involved in research gives you access to other kinds of PET scans. There would be some lab work, so the primary care doctor would, they draw some blood, they look at vitamin levels in the blood, they look for signs of infection. And there may be a neuropsychological evaluation. So this is a specialist who does a more extensive cognitive test. So not just, many of you, if you've been in the doctor's office yourself or with your loved one, they might ask you a test that ask you some questions and have like a 30-point scale. And the screening, the test might take, 10 minutes, not very long. A neuropsychological evaluation would be much more expensive. It would be at least 2 hours or more, many different kinds of tests, to really get a more clear idea of how different parts of the brain are functioning. So to get to a diagnosis of dementia, and especially reaching a diagnosis of a certain type of dementia, like Alzheimer's disease, it's really ruling out all of the other possible causes and then looking for clues that support your conclusion, right? Looking at brain scans, looking at symptoms, behavior, response to medications, different kinds of things that help that physician come to a more accurate diagnosis. So I often get the question, well, what's the difference between Alzheimer's and dementia? And hopefully you have an idea about what that answer is based on what I've shared so far. Alzheimer's is the most common form of dementia. There are many types of dementia. If you have Alzheimer's, you do have dementia. If you've been diagnosed with dementia, that's not really telling you anything about what type it is. Could be Alzheimer's, could be vascular, could be Lewy body, could be something else. So seeing your primary care doctor gets you to the point often of dementia, but then it's often a specialist who steps in and really gets you to the point of knowing what type of dementia someone is experiencing. I do advocate that you find out what type of dementia your loved one has, if at all possible. Each type of disease may progress differently. The symptoms are a bit different, the treatment might be different, the longevity, the information that you can gather, the resources that you might need, the peers, other kinds of caregivers you want to connect with. You want to be able to connect with people who really understand what you're going through. So knowing what type of dementia is happening gives you more information. Each person is really different though. So you've maybe heard the saying, if you've met one person with Alzheimer's, you've met one person with Alzheimer's. No two people are the same. Even if you were the same age, the same sex, the same, kind of stage within the disease, no two people are experiencing the exact same thing. So the progression will look different. So just for example, with Alzheimer's disease, when we think about someone's life expectancy, you'll read online, average life expectancy after a diagnosis is about 8 years. but really the range of what's possible could be anything from a couple of years to more than 20 years, right? So that can be a very different experience for each person. Comorbidities may play a role, depending on someone's age and the other kinds of diseases, illnesses, conditions that they're experiencing, that can play a role in the progression of the dementia. It is really important to learn what type of dementia your loved one has, if at all possible. So I see benefits of early detection and diagnosis. People will sometimes say to me, well, why would I even want to know that I had dementia? There's no cure anyway, right? What's the point? Having that early detection, not putting it off, not putting your head in the sand, and having that early diagnosis have a lot of benefits. It allows you to involve the person living with dementia in the decision making, right? To be part of that conversation. What do I want for my future, right? To be able to understand what my wishes are, what my opinions are, early on in this process while I have the ability to communicate that to you. That early detection and diagnosis allows for appropriate medical management. The way that we might treat symptoms of different forms of dementia varies. There are medications that are FDA approved to help treat Alzheimer's symptoms, but you wouldn't necessarily use those same medications in a different form of dementia. Or there may be more kind of co-occurring conditions that happen with certain types of dementia and different kinds of medical management that need to be in place. Having an early detection, early diagnosis really allows more time for long-term care planning. Do we have the resources in place that we need? Do we have the funds? Do we have plans? Where are we going to get care someday when we need it? And if you're the care partner, how does that affect me? That early detection and diagnosis allows for involvement in clinical trials. We live in those of you who are in Northern Virginia or in Prince George's County or the DC metro area with me, we have really great access to research centers here. So these research studies are generally looking for people who have an early stage diagnosis or MCI. And so that's something that person can do to be active, to do something to contribute to a body of research, to hopefully prevent family members, future generations from having to face some of these same things. And having that early detection and diagnosis allows for access to resources and development of a care team. It's always helpful to learn about what's out there before you need it. I can't tell you how many times I hear from people. In fact, just today I heard in an email from someone, I wish I would have known about this 4 years ago. It would have helped me so much, right? Look for the resources early on, even if you don't expect that you will need them for years and years to come. So treatment goals. Let's say there is a new diagnosis. What can we expect for treatment? There are some medications that might improve symptoms. So I mentioned there are some medications that are FDA approved to help with Alzheimer's symptoms. Sometimes those medications can be helpful with other forms of dementia. Those medications, by the brand names, you may recognize Aricept, Namenda, Razidine, Exelon, these types of medications. And I just want to be clear that unfortunately these medications are not actually slowing down the progression of the disease. They're not curing the disease, but they're helping the brain compensate for some of the changes that are happening for a while. So they can be really, really helpful for the right people who are taking them at the right time in the disease progression. When I talk with doctors about what's most important for the person living with dementia, what they say is physical and social activity. These are the most important ways to ensure the best quality of life possible and also to maximize functional independence. My ability to move around throughout the day, my ability to interact positively with other people. So a lot of folks are, they ask me about things like brain games or different kinds of exercises to try to slow the progression of the disease. And I'm not saying that any of those things are bad, but really what the research shows us is physical and social activity are the two best things for someone who already has a diagnosis. Treatment includes support and guidance for care partners. Doctors are increasingly recognizing that the care partner is is right in that same circle with the patient, right? It's not just my patient that's my patient. The care partner is an integral part of this relationship. So one of the best ways we can treat these diseases, treat the symptoms, provide the best quality of life, is to make sure that care partners get the right information and get the right kinds of supports for themselves. And again, treatment might mean getting involved in a research study, which gives you great access to experts in the field, additional visits with providers, additional conversations, maybe even additional resources. When someone has an early stage diagnosis, we might want to consider environmental changes. The home as it is, or as it has been for many years, might not be conducive to what this person is experiencing. One of the things we might want to consider is removing some of the clutter. So if your loved one, for example, has a hard time finding something that they need, when there's a lot of clutter, it's only making that problem worse, right? Or if your loved one can't quite figure out what they need to do next, and the dining room table is covered. I mean, the meal is sitting there, but the newspaper is sitting there, and the bills are sitting there, and something else is there too. It's more confusing about what my task is right now. So removing some of that clutter, making the space a little more just dementia friendly would be helpful. You might find that using labels or visual cues is helpful. So let's say my husband really wants to help me put away the dishes from the dishwasher, but the pans end up where the coffee goes, and everything is in the not the right place. You might find that putting some labels on the cupboard could be helpful, or labels on your dresser drawers, or maybe signs and arrows pointing towards the bathroom. And in the early stage of the disease, using words might be effective, but into the middle stage, you want to use more like pictures, more visual cues rather than words. Rather than putting a little sign next to the bathroom that says toilet, maybe you put a picture of the toilet right there by the bathroom. Other environmental changes, you might have to change the tools or materials or equipment that your loved one uses in activities. So maybe my loved one, really loves to go out to the garage and has lots of, hands-on hobbies, woodworking, something like that. You might need to change the types of equipment that are available so that person can still do what they want to do, but in a safe way, if at all possible. Or let's say my loved one always, they do the crossword puzzle in the newspaper every day, but now it's starting to become frustrating. Maybe it's getting a crossword puzzle book that's a little bit different level, that's a better fit for my loved one. And we might consider modifying the physical environment. Is it well enough lit? Are there noises that are confusing or overstimulating? Do we need to change anything else to make the environment a little more suitable for my loved one? We want to think about ways to manage cognitive dysfunction. So that might mean providing some gentle verbal cues with some specific prompts and positive reinforcement. And we're going to talk next in our next webinar a lot more about communication. So we'll come back to that next time. We might simplify the activity or break it down into more manageable, smaller steps, or providing a little bit of cueing. So maybe rather than my loved one going outside and pulling weeds on their own, maybe we go out and we do that together. Or maybe I just make sure that all of the right tools are in place so that my loved one can then go out and do the things they want to do. You don't have to go to the shed to find the gloves and find the right equipment. I've got it ready for you. One of the really important things, and especially right now while we are all at home, is to create a predictable, structured routine. So important in dementia care, and especially so important right now when you may find that your routine, whether you realize you had one or not, has been disrupted. So trying to put specific kind of markers during the day. We get up around the same time every morning. We do things in a pretty similar order. After we finish, getting ready, we have breakfast and we have pills, and then we go for a walk. Or then we sit down and we work on a puzzle together. Or maybe right before mealtime, we put a favorite song on just to kind of be a cue that we're about to shift gears and transition to something else. Trying to create a routine is going to be really, really helpful for you. We might use some distraction and meaningful activities when there are behavior changes or when there's just kind of a lack of structure or a lack of purpose. So we'll talk more about that in future webinars. One of the things I would suggest to you is to let your loved one know about events just when they need to know, like right before they occur. I would not tell them really far in advance. So let's say you have a family member coming to visit next month. I would not necessarily tell your loved one that next month Aunt Susie is coming for a visit. I might wait until the night before Aunt Susie comes, right? Or depending on your loved one and where they are in the progression of this disease, maybe you tell them a week or a few days ahead, or maybe you just tell them that morning, a half hour before Aunt Susie shows up. There's a lot of trial and error in dementia care, and so it's figuring out what's the right fit for my loved one. But if you find that when you tell your loved one something and they ask you about it over and over and over again until it happens and it's really frustrating you and maybe it's really frustrating them, wait, don't tell them so far in advance. And in that early stage, you do want to address any difficulties with IADLs. So these are instrumental activities of daily living. This is something like driving and bill paying, right? It's these things that require higher cognitive function. So there will be at some point some changes in the ability to drive, for example. So addressing those things early on, just having a diagnosis of dementia does not mean that you instantly, can't drive because that diagnosis has been made. But we know that these are progressive conditions in the brain, and there will come a time when that isn't safe. So really addressing those changes early. Another thing that comes up pretty early on is usually managing finances. We want to address depression and apathy. For someone who has a new diagnosis, who understands the extent of their impairment, or has some idea about, how this disease is going to play out, they could be depressed over their losses, right? And that's natural, that's to be expected. But it doesn't mean we want that person to kind of sink into a deep depression. We want to make sure that they have the supports in place, to live the best quality of life possible. As dementia progresses, there's usually a little bit less self-awareness and it becomes a little bit more apathy. And apathy is also really common when someone has FTD, just because of where those changes are happening in the brain. Apathy becomes quite common. So when that diagnosis has been made, it's also time to start getting our ducks in a row, personally, legally, and financially. So we need to start the conversation. We need to start educating ourselves and our family members about this disease. Do all of the adult children really understand what dad is facing, right? Does everyone really have a basic idea of what's going on? And the people who are more directly involved in care, do they know the things that they need to know to be as prepared as possible? You want to decide when and how to disclose the diagnosis. When do we tell our kids, or when do we tell our siblings, or our best friends, or our acquaintances, our neighbors, our colleagues? And this is a really personal decision. And I would say going to a support group is a great place to kind of bounce around some ideas and hear how other people have disclosed the diagnosis to different kinds of people in their lives. You want to start using effective communication techniques. And again, we're going to talk about this next week, but just in a nutshell, like I was mentioning, maybe you don't tell all of the information as soon as you know it. Maybe you wait until your loved one needs to know. Or if you find that your loved one really struggles with decision making, maybe instead of looking at a menu in a restaurant and inevitably my loved one is going to say, well, I'll have what you're having. Maybe if we can just give a couple of options, my loved one could be more successful and independent in that decision making, right? So there are lots of little kind of tips and techniques that can help with communication. In the beginning, when that diagnosis is made, we do want to involve the person living with dementia in all aspects of planning while they have the capacity, and to respect their wishes to the extent possible. Now, I understand there are people who have a diagnosis who don't remember that they have a diagnosis, who disagree with the diagnosis, who may be emotionally in denial, who may cognitively not be able to absorb that information and understand it. So I'm not saying to force a conversation. I'm not saying to like make your loved one agree or make them understand. But I'm just saying if there's an openness to this, if there's a willingness to have a conversation, involve your loved one in those discussions while they're able to. It's important to start reviewing finances and getting your legal documents in order. So that's a whole other topic that we won't have time to cover today, but just generally thinking about things like advance directives, power of attorneys, how are our finances, what are our assets, what kinds of programs might we be eligible for, if we need some support in the future, really getting all of that information together and using it to, to your advantage as much as possible. And then when you're starting the conversation, I do encourage you, if you're the caregiver, to really start thinking about what are my abilities as a caregiver. Maybe I'm super organized. I'm happy to coordinate people. I'm happy to make phone calls, get everything in place. But what are my limitations? I am just not comfortable helping my mom in the shower or in the bathroom, right? Or I know that I need a certain amount of time to myself every week, because if I don't get that yoga practice in, or if I don't keep up my volunteer responsibilities, it's not going to be good for me. So whatever those things are, being honest with yourself, including that in that conversation about the future. What are my abilities as the caregiver, and what are my limitations too? No one can do everything. So it's important to put together a care team. It's not just you, if you're that care partner. In the beginning, with that early stage diagnosis, you might feel like, that things are a little different, but I think I've got it all under control, and maybe you do. But things will change in the future, and you're going to need more support around you. That care team could include family members and friends. It could include healthcare providers, the primary care doctor, the neurologist, other kinds of healthcare providers, that you're in touch with frequently. It could include organizations, community groups, faith-based organizations. Maybe my church has some resources to tap into. Maybe there's a nonprofit near me who supports people living with dementia or caregivers. Maybe there's a volunteer-based group that will help give my loved one rides to the places they need to go, or to pick up groceries for us if I can't get out, those kinds of things. You want to think about including other professionals on your care team. Maybe it's a counselor or a therapist. Maybe it's a physical therapist or occupational therapist. Maybe it's a dementia consultant of some type. Who else do I need? Who has the information that I need? Who can support me and guide us in the right direction? And again, it's really important to familiarize yourself with resources before you need them. Don't wait until a crisis occurs. Don't wait until there's some unexpected thing that happens, like a hospitalization, and now you're completely at a loss of who to call or what to do. Familiarize yourself with the resources early on. And make a plan. So what healthcare, legal, financial decisions do I need to consider for the future? And especially in the early stage, this is the time for your loved one to sign any legal documents that might need to be signed, right? Their capacity to understand those documents will change, and different kinds of documents require a different level of capacity. So getting all of those in place early on is going to be one of your first steps. And those are really things that we should all do. No matter what age we are, we should all have all of those documents in place. So there may be a different angle to approach it if your loved one is saying, well, there's nothing wrong with me. My memory is just fine. I don't know what you're all talking about. These are the kinds of documents we should all get in place. And even if we have them, they should be reviewed on a regular basis. So your plan should also include who are those other sources of support. Who are those friends, those neighbors, family members, who are the professionals who are going to be able to support us in the future. We want to be able to discuss care values and the role that they'll play. So if I'm living with this diagnosis, what's most important to me? Is it to be independent? Is it to be with family and friends? Is it to not be a burden on my family? What is it that's really, really important to me? And being able to discuss that early on. We want to be able to learn from this person, what do they prefer for future care? Do they prefer family members, professionals? What kinds of, who would help with different kinds of care that might be needed? Who I I'm comfortable having, to drive me around, it might be very different than who I'm comfortable having help me in the shower. And then when this plan is being put together, it's important to communicate it to family or to those other people who are very close to you. You might be, maybe you're a married couple and you know each other's plan. You've, developed a plan together. Maybe you've worked with a doctor to put a plan together or a consultant of some kind. But have you actually communicated that to your family members? It's really important to do that early on. There is an evidence-based program available that does help address future care. It's called SHARE, and SHARE is from the Benjamin Rose Institute of Aging in Ohio. And the goals of the SHARE program are to support SHARE partners, help them communicate more effectively as they plan for the future, to promote the health and well-being of both SHARE partners, reducing their stress, to encourage both partners to take better care of themselves and engage in activities that they find fulfilling and meaningful, to learn about community resources that support the SHARE partners' values and preferences, and to also provide education about dementia and how to manage some of the changes that lie ahead. So this is a program that is really for the person living with that early stage diagnosis and their primary care partner together. There are a number of different organizations that offer the SHARE program all across the country. And at the end of the slides, there will be a link to the Benjamin Rose Institute where you can learn a bit more. Here in the DMV area, Insight Memory Care Center offers the SHARE program, and we do offer it virtually. And there's more information about that on our website. And finding support, so important. Both support for the caregiver, we think about that a lot, but also support for the person living with this diagnosis. They might feel like they are the only one. They know nobody else who has, early stage Alzheimer's or who has FTD or something else. So finding and seeking out support for both of you. That might mean a support group. There are tons of support groups around. We're going to share a few later on in the slides. There are support groups that are happening by telephone, that are virtual, and eventually in person again. That might break down by disease, by stage, for couples, for one person or the other. So really a lot of options there. The support might be a counselor, a therapist. It might be friends, family members who really get it and are there for you. So look for those community resources. What is around to support both of us when we need it? You might consult with a professional. That's a great place to get support. Somebody who really understands how to support people who live with dementia and their care partners. So that might be a dementia consultant of some kind or other sorts of professionals. You might hire help. So yes, there might be in-home care in your future, but if you have a new diagnosis and your loved one is still early stage, you might think, well, we don't need caregivers coming into our home yet. But you might find that there are other kinds of services that are really helpful. As you as the care partner are taking more and more and more on your shoulders, more of the household responsibilities that you might have shared with another person are falling on you. Maybe you hire that housekeeper, right? Or maybe you hire somebody to come and take care of the yard, or maybe you have a friend or a family member or somebody in your faith community who will offer to support you with different kinds of tasks that allow you to pay attention to the things that are most important for you. You might consider, how do we secure safety? How do we make sure that the home is as supportive as possible? And then looking for housing with supportive services. Again, just knowing what your options are for the future. You may have a goal of keeping your loved one at home with you forever and ever. Maybe you made a promise about that. But still, I encourage you to understand what kinds of housing options are out there, because sometimes things happen that are unexpected. Possibly a hospitalization, maybe there's a fracture or a significant illness, and it just is not safe to come back home. So rather than waiting for that kind of situation to occur and then trying to figure out what to do, understand what your options are early on. And most importantly, take care of yourself. It can be really hard to be a working caregiver. Some of you are probably experiencing that right now. look for support. You know, what kinds of services does your employer offer? Can you flex your time? Can you change your hours? You know, are there employee assistance programs or wellness benefits that you can tap into, or even family medical leave? You know, really understand the financial impact that different choices will have in the future. What if I leave my job to be a full-time caregiver? How does that affect our financial security in the future? Not just for my loved one, but what if I need some care someday? What if we make decisions about using an adult day program or in-home care or assisted living or something else? How do those affect our financial security in the future? So you want to make sure that you're part of that picture, not just what's best for my loved one, but I need to make sure that I'm going to be okay in the future too. You want to advocate for yourself. If you're feeling something, if you're needing something, if you have a question about something, you got to be the squeaky wheel, right? You got to say it. You got to ask somebody. You got to tell somebody what you need. You have to let people know. Often the focus shifts so much towards the person living with the diagnosis and what they need that we forget that the caregiver has needs too that are greater than ever. Recognize your emotions. If you're feeling sad, if you're feeling angry, if you're feeling resentful, if you're feeling relieved or you're feeling grateful, whatever those things might be, really recognizing those emotions, because you're not alone and you're not the only person who has felt those things before, and they're not wrong. So really recognizing how I feel, and if I need some new tools to kind of manage those feelings and work through them, great. Be that advocate, figure out what those tools are. Get connected to people who have felt the same way too. They're going to be a lot of support to you. Take care of yourself, live a healthy lifestyle, get enough sleep, eat well, move your body, keep up your social connections. I know that's so much easier said than done, but it really, really is going to be important as you continue forward. And look for caregiving services and support groups in your area. You're probably going to be surprised by the resources that are available. And so I just want to remind you that this presentation is part of Dementia Friendly America's initiative, specifically Dementia Friendly Prince George's County Northern Sector. You can learn a lot more about Dementia Friendly America and all of the different communities that are involved in this movement online. Specifically in Prince George's County, there are a couple of virtual support groups that meet, so please consider connecting with one of those. There's a monthly email newsletter. I'll remind you that we have 2 more segments of this series, so I hope you can join us the next 2 weeks for understanding communication and behavior changes, and also person-centered care at home. And these webinars will be posted on Dementia Friendly America Northern Prince George's County's YouTube channel in June. And a few resources available for you. Prince George's County, Maryland's Area Agency on Aging. The phone number is there at the top of your screen. If you are not in Prince George's County, wherever you are across this country, you have an Area Agency on Aging. Or let's say you're in Prince George's County, but your loved one is in New York. What's their Area Agency on Aging? You can go to n4a.org, put in a zip code, find out where that local Area Agency on Aging is and how to get in touch with them. There's some great resources through the National Institutes of Health. I mentioned the SHARE program and a link to learn more about that. So wherever you are around the country, you can also learn more about the SHARE program and find out if there is anyone near you offering the program or virtually. And then another really great resource is AARP has a guide called Prepare to Care. And if you go to their website, you can either download an electronic version, or you can have them mail it to you free of charge, or give them a call. So I encourage you to pick up one of those Prepare to Care guides as well. There are a number of larger nonprofit organizations that serve our entire country. So for Alzheimer's, there's the Alzheimer's Association and the Alzheimer's Foundation of America. There's a Lewy Body Dementia Association, and there's an association for frontotemporal degeneration. So on your screen, you have the websites and phone numbers to reach each of those. And if your loved one has a more rare type of dementia, there are organizations to support them too. So do an internet search and you will find something, or contact me and I will get you in touch. And another resource for all of you, no matter where you are, is Insight Memory Care Center. We offer care in Northern Virginia, but also education and support for anyone. So there are lots of classes that you can tap into, support groups, consultations. You are welcome to contact us, and we'd be glad to help you or to get you in touch with resources that you might need that are near you. And here's our contact information. And I thank you all so much